I've got good news and bad news. Here's the bad news. Most protein bars are packed with sugar and unpronounceable ingredients. The good news? There's a better option. I'm Will, and I created IQ Bar plant protein bars to empower doers like you with clean, delicious, low-sugar brain and body fuel. IQ bars are packed with 12 grams of protein, brain nutrients like magnesium and lion's mane, and zero weird stuff. And right now, you can get 20% off all IQ Bar products, plus free shipping. Try our delicious IQ Bar sampler pack with 7 plant protein bars, 4 hydration mixes, and 4 enhanced coffee sticks. Clean ingredients, amazing taste, and you'll love how you feel. Refuel smarter, hydrate harder, caffeinate larger with IQ Bar.
Go to eatiqbar.com and enter code BAR20 to get 20% off all IQ Bar products plus free shipping. Again, go to eatiqbar.com and enter code BAR20.
You're listening to an Airwave Media Podcast.
I am a scientist. I am a scientist. I am a scientist. We gotta live on science alone.
Welcome to Unbiased Science, where we bring scientific method to the madness. We're your hosts, Dr. Jessica Steyer
and Dr. Andrea Love.
And this week, we are joined again by Dr. Craig Chepke, board-certified psychiatrist, who joined us recently for an amazing episode on postpartum depression. That was such a fantastic conversation that we invited Craig back to talk about another mental health issue / disorder, attention deficit and hyperactivity disorder, ADHD. Craig, I'm going to read your very impressive bio right now to introduce you to the world once again. So Dr. Craig Chepke is a board-certified psychiatrist and has been named a distinguished fellow of the American Psychiatric Association. He attended NYU School of Medicine and completed his residency training at Duke University. In addition to his clinical practice, Dr. Chepke is an adjunct associate professor of psychiatry for Atrium Health. Dr. Chepke has special interests in treatment-resistant and serious mental illness, movement disorders, sleep medicine, and ADHD. His approach is to personalize treatment to each individual person, from the newest leading-edge medications to older, underutilized treatments such as lithium and clozapine. He also strongly emphasizes psychotherapeutic interventions and physical health and wellness through exercise, dietary modification, and supplementation. He is active in clinical trials and serves on the board of directors of nonprofit organizations benefiting schizophrenia and Huntington's disease. Craig, thank you so much for joining us again.
Well, thank you so much for having me back, Jess and Andrea. I could not be more delighted to be here today.
So let me set the stage. So I'm sure everyone has heard of ADHD. Many people probably have also heard of ADD, which is no longer a term that's used. But ADHD, or attention deficit hyperactivity disorder, is a neurodevelopmental disorder that's characterized by patterns of behavior that include hyperactivity, impulsivity, and inattention. And it is quite prevalent amongst both kids and adults. And we're going to get into some of the meat of this conversation. But very quickly, when we look at the estimated number of children, that's children between the ages of 3 and 17 that are diagnosed with ADHD, by surveying parents, the estimates are around 6 million, which is about 10% of children. And that's from data over the last 5 to 10 years or so. You're seeing highest prevalence of diagnosis among school-age children. So children from either kind of 6 to 11, so that preteen age group, or between 12 and 17 years of age. And ultimately, there's some variability in diagnosis, right? So there's state-by-state variability. There's also variability in prevalence or diagnosis amongst different ethnicities. So you're seeing that Black, non-Hispanic children and white non-Hispanic children are more often diagnosed with ADHD as compared to Hispanic or Asian children. And we see that boys are almost twice as likely to be diagnosed with ADHD than girls. But we're going to talk a little bit about whether that's really prevalence or whether that is limitations of diagnosis and clinical presentation. And we are seeing some of the changes where adults are now being diagnosed with ADHD after likely having it for most of their life. And Craig's going to get into why there might be this diagnostic gap in a little bit. But I happen to be one of those people. I was diagnosed with ADHD in May after thinking for almost 20 years I had only depression and anxiety. Turns out I also have ADHD. I'm now being treated for it, and it's kind of phenomenal how much of a difference that makes.
This is clearly something that touches us all personally. My son, I don't even know if I shared this with you, Andrea or Craig, just last week was formally diagnosed with ADHD. And so we're navigating how to handle that now. But Craig, maybe we could turn things over to you to sort of, talk to us about what do we think causes ADHD? What do we know? What don't we know? Let's lift the curtain.
Well, before I even get into that, I want to say it touches me personally as well, and in a similar fashion to both of you. So, like Andrea, I was not diagnosed until much later in life. For me, it was after I finished my psychiatry residency, unfortunately, after college, med school, and residency at age 30. And also 3 of my 4 kids have been diagnosed with ADHD, and the 4th is only 2, so we have no idea as of yet. So this is something that is really important to me personally as well as professionally.
And I was going to say, it sounds like you might be alluding to the fact that there might be a genetic component to ADHD.
Absolutely. When talking about what do we know and what don't we know, the vast majority is going to be in what don't we know. And that's the case with most psychiatric disorders because the brain is just almost impenetrable, at least to our scientific knowledge thus far. It's a lot easier to examine the heart, the kidneys, the lungs than it is the brain. It's the toughest organ in the body to study and the most complicated as well. And there's a lot we don't know, but there is definitely a genetic component. The quick and dirty thumbnail way to put it is that ADHD is roughly about as heritable as height. So if you are a tall person, you're going to be more likely to have tall children and vice versa. And ADHD is as heritable as height, roughly. It's tremendous heritability, more so than most other psychiatric disorders. So it is very common. And what are those genetics? Well, it's vast, it's complicated, it is multifactorial. This is not a single gene. This is hundreds, maybe thousands of genes that are coalescing together to come up with this particular diagnosis. And so we don't know exactly what causes it, but kind of working backwards, we do know that most of the medications that are utilized to treat ADHD have functions in serotonin and norepinephrine, and they can modulate those 2 neurotransmitters. That doesn't mean those are the only 2 neurotransmitters involved. Clearly not, but there's got to be something going on with those 2 neurotransmitters at least, but there's also interplay. You can't touch anything in the brain without having a downstream effect on others. So certainly serotonin is going to be involved, glutamate, GABA, just in ways that we're just not smart enough to elucidate yet. But there's some dysfunction most likely in the frontal cortex. The frontal cortex is where things like executive function and control tend to live, and several other areas of the brain, but really more the circuits of the brain is probably a better way to talk about it, because it's about the connections between the different areas of the brain and how the communication goes, rather than just a specific area in the brain. We believe is a more advanced and modern way to think about it.
There's also evidence now that in addition to having these genetic contributions, the actual encyclopedia of all your DNA, there's also factors that we call epigenetic factors, which are modifications of the DNA itself that make it more or less likely that those genes will be expressed. And so there's these proteins that will wrap around the DNA kind of like pearls on a string, and they can make it more or less available to turn into a functional gene. And those are also inherited or can be inherited. And we're finding that there's likely some of these components that are involved in the presentation or development of ADHD as well.
Yeah, absolutely. And those can be, the epigenetics can be influenced by things like early life adversity, which can be passed down through generations. Environmental exposures can affect the expression of our genes. Overall, I really love the concept of epigenetics because our destiny is not written in the stars, so to speak, that our DNA is the same always, but as you said, the way that we express the DNA can be different. So that, to me, is an incredibly hopeful characteristic, because if negative life experiences can negatively influence our gene expression, that means the opposite must be true as well. And positive life experiences can break that cycle and can result in healthier expression of certain genes.
Yeah, no, it's absolutely true. It just adds to the complexity of understanding everything, right?
We get a bunch of people DM us all the time, and I'm trying to think about what some of the claims are. But basically, there's a lot of concern about prenatal, perinatal things going on that might impact likelihood of a child developing ADHD. Andrew, I'm trying to think of some examples of things.
So they talk about toxin exposures and consuming caffeine and smoking and alcohol and drug use, a lot of those sorts of things. And of course, a lot of this ends up like coming across as victim blaming in many ways. And I think it's really important for people to understand that, as Craig said, this is multifactorial, and we don't even, we haven't even parsed out, a fraction of the contributions. So it's extremely unlikely that a single thing, a single behavior is going to cause or not cause something. So,
Right.
We have to stop with kind of the parent shaming and all of that. But on top of that, just because you have a gene that may be associated or implicated in any disorder, whether it is cancer or ADHD or anything like that, doesn't mean that you're 100% definitely going to develop that condition. It's the same with these gene mutations that are associated with breast cancers or other cancers. It increases your likelihood. It does not guarantee.
Yes, we really need to make a shirt, Andrea. Let's make note of this for merch. Health is multifactorial. We say it ad nauseum in every single episode and every single post. But it's just coming back to me. I mean, we've heard things about maternal Tylenol use during pregnancy, things like food dyes, things like that, where we really just don't have any strong, compelling evidence that says definitively, that this causes ADHD. And exactly as we're all saying here, it's not as simple as that. It's also multifactorial. But Craig, are there certain prenatal, perinatal, anything that we should be aware of when talking about ADHD?
Well, one thing that I'm reminded of is when I was on the pod for the postpartum depression talk, one thing that I said applies here: whatever you do as a mom, it's wrong, according to the internet. So that's applying here as well. But, some of the things that have been associated, again, association, not causation, but, as things like smoking and, I almost hesitate to get too much into specific factors for fear of perpetuating them. But, living as healthy of a lifestyle as one can is going to be beneficial to the woman and to her baby in various ways. That's probably maybe just the best way to say it. I mean, ultimately, as parents, we just do the best we can, and no one's perfect, and we just do whatever we can.
So, Craig, let's talk a little bit about, how it's diagnosed and the history of how it's diagnosed, how it was characterized in the DSM, and why we may see some gender differences. Because historically and stereotypically, it's often thought that boys have ADHD more than girls. And some of those stereotypes, and that can be either in the classroom, within parents, even in healthcare providers, that influences the frequency with which boys and girls are diagnosed during childhood. And so the criteria for ADHD has kind of been stratified over the years. So maybe you can walk us through some of that. Yeah.
So you alluded to earlier, Andrea, that there's a term ADD, attention deficit disorder, which is kind of obsolete now. An earlier term than that in early DSMs was actually MBD, minimal brain dysfunction. What a great name, right? It's just minimal brain dysfunction. So it's gone through many different permutations, and I like to say that psychiatry can't name anything right, and ADHD is definitely one of those, no matter which one of the incarnations that it was. But so the current construct as we know it of ADHD did start previously as ADD. And now in the DSMs, starting with DSM-4, there was changed to the ADHD from ADD, but there are subtypes. There's ADHD inattentive type, ADHD hyperactive type, and then ADHD combined type, where there's prominent features of both. And so basically, ADHD inattentive type is what we used to call ADD, but it just technically is no longer used in a medical sense. But it's still very, very commonly used in pop culture. But this construct was really defined based off of the symptoms that are presented by more or less 6 to 12-year-old boys. That's it. They define the set of criteria based around the 6 to 12-year-old boys. That's what they did the field tests on. The DSM uses field tests to test the validity of it. And so really the current diagnostic criteria have only ever been designed for and field tested on 6 to 12-year-old boys, not even 13 to 17-year-old boys, girls of any age, adults of any age, or adults of either gender. So it really is very limiting. And going along with that, the way that we are trained in medicine to look for it is really not conducive either. Really, what I remember about it from my psychiatry training is more or less, if you do a child adolescent fellowship, that's where they'll teach you about it, is my remembrance of the kind of the take-home message. And so is it any wonder that as adult practitioners, we're not very good at recognizing ADHD because we didn't learn about it. So the children who get diagnosed with ADHD, they age out of their providers who know what ADHD looks like more so, in my opinion, than they age out of the condition themselves. So that's one of the biggest misconceptions is, they'll grow out of it. And also one other thing that I picked up on that you said in the intro that is one of my huge points. One thing the DSM did right is that in DSM-5, they moved it to the neurodevelopmental disorder section. And that is a huge change because it sits right in between autism spectrum disorder and specific learning disorder, which I don't think anyone would argue that people grow out of those. And what those two diagnoses do say in the DSM, which right now ADHD doesn't have language like this, but I'm hopeful that one day it could, because I certainly believe it to be the case, is that these are conditions that people can have, but that the symptoms can be masked by certain adaptations that they have, certain structural advantages that they may have in terms of loving, supporting family who is able to afford tutors or who can have time to help the children through and provide scaffolding for them in terms of organization and support. Certainly, I had that in spades with my mom, who is literally still my secretary at my office, still providing me that support and scaffolding to this very day. So if you have that kind of scaffolding, and also another one is intelligence. There have been studies showing that the higher the IQ is correlated with a later age of diagnosis. The way that I kind of put that to patients is that you can just kind of brute force IQ your way through earlier schoolings and things like that. And you can still get pretty good grades or very good grades even, but it can come at a cost. It can be a double-edged sword because you may have to work 2, 3, 4, 5 times as hard as all the other kids or adults who don't have ADHD who are getting similar results. And again, that's what I found myself growing up, is that I just worked my butt off. I seemed to have to work way harder than anyone else in any of my classes to get those same results. So yeah, I got good results, but it came at a cost.
I'll quickly kind of run through. So as you mentioned, the criteria, even as they're listed in the DSM, are really geared towards young boys. It's talking about fidgeting in your seat, avoiding schoolwork, not being able to prepare homework, easily distracted by external stimuli, forgetting to do chores, so on and so forth. And so when we're talking about, the inattentive presentation, this is a situation where, you're not able to focus on things that are not captivating your attention. So, I hear a lot of times it's like you're looking for that dopamine hit, and the things that are really menial to you are the things you're going to avoid, like the plague. And that was always me, right? Like I would sit there and fixate on infectious disease textbooks as a child, but I couldn't, vacuum my room. I couldn't put my laundry away because that was boring, right? The hyperactivity is that motor fidgeting, right? The activity, the can't sit in your chair, the leg tapping, the pencil tapping, the nail picking, all that sort of stuff. And so, as you mentioned, a lot of people are able to mask this. I happened to, have higher than average IQ, and I was in a school program that was really less focused on textbook learning and more on creative projects. And so I really kind of funneled my energy into all those creative projects, which was a good outlet. But, getting diagnosed at 36 years old after graduate school, after being in a career for 9 years, beyond that, I'm like, man, grad school could have been so much easier if I had been diagnosed and was managing this correctly. Because, my psychiatrist nowadays was like, I've tried all these different meds for depression and anxiety, and I still, experience this excessive fatigue by the time the weekend rolls around, or this constant daily headache. And he's like, it sounds like your brain is just working too much. Like, your brain shouldn't have to work this hard. And the first day I took my new medication, my headache went away. And I was like, but it the amount of difference, it's kind of like, he describes the inattentive as internal hyperactivity, because you're still hyperactive, but it's your brain internally processing all of these different stimuli all at once, and it's all kind of jumbled together, and you're trying to sift out what you should be focusing on and what's extraneous. Whereas the hyperactivity presentation, it's that physical manifestation of it.
I love the way that your psychiatrist talked about it, but I'll tweak it just a little bit for the way that I think about it. Is that really, I think that the core concept in this condition is impulsivity. And that applies equally to inattention and to hyperactivity. It's almost like people with ADHD have malfunctioning brake systems in their brain. They can't put the brakes on and stop themselves from moving around. They have motor impulsivity. And same thing with the inattention. It's definitely not attention deficit disorder. The biggest misnomer, because as you said, you could focus on immunology. That's a common thing that parents will say, oh, my kid can't have ADHD because they can play Fortnite for 12 hours straight. It's attention dysregulation disorder, is that they're not able to shift the attention appropriately to where it needs to be. It can lock onto something that they're interested in, and they hyper focus on it. And so they can attend to things. But let's say the fire alarm goes off and Johnny, we got to go. The house is on fire. Okay, just let me get to the next save point, Mom. They can't shift the attention. Or alternately, if they're in a boring situation, which maybe could be a classroom and a squirrel goes by stereotypically, then that impulsivity, they can't keep their focus on their teacher. They're looking at the window, looking what the classmate's doing. I happen to find that after some period of time, I would always sit in the front row if I wasn't assigned a seat. I didn't have anything else to look at but the teacher and the blackboard.
Interesting.
So that was kind of my natural adaptation to it, was that I found that, things seem easier when I sit in the front row. I'll just be that kid who gets there early and sits in the front row. And to this day, I still do that just because it's such an ingrained habit now, but it's functional and it works. But it's the impulsivity. And that's also the thing that is very dangerous about ADHD that I think is really underappreciated, that a lot of times people think, so you can't necessarily pay attention as much and, you just sit still. Mm-hmm. Well, impulsivity, and that leads to things like medication holidays, whether it's over weekends or summers. And that is a really tremendous mistake in my personal opinion, because this is a 24/7 condition. Mm-hmm. I mean, and if you think about it through the lens of impulsivity, it makes a lot more sense. There are voluminous studies showing that for children, there's greater rates of broken bones and other injuries. For adults, that a really cool study design that looked at the same individuals months that they took, filled their ADHD medication, presumably took it, versus months they didn't. That the months that they did not take their ADHD medication, there was a statistically higher rate of motor vehicle accidents. And if you think about it, driving is nothing but impulse control, because you're sitting at a yellow light trying to figure out, do you try and turn left to cross traffic, beat the car in front of you, or do you just wait for it to pass? You've got a split second to decide. And that impulse control is critical. Also, people. Oh,
no,
go ahead.
No,
Yes.
go on. You're on a roll. Go for it.
I'm on fire right now. This is just so important. I think just not appreciated. And things like people who have no filter verbally, being able to control those verbal impulses of, do I say things exactly as they come into my brain, or do I wait about 3 seconds and then say it in a way that's going to be more helpful, useful, polite, not offensive, whatever it might be. And people with ADHD, just that they don't have that filter, or they have a much shorter one. And then with treatment, it can restore that filter. Now, that doesn't mean that it takes them off the hook after that 5-second tape delay of the filter being put back on. They can still say something dumb, but at least the medication put them back on equal footing with the person without ADHD.
Craig, I have to say, I love the framing as an impulsivity, condition, because it's absolutely correct, and we even see the comorbidities or co-presentations or trends are reflective of that, right? You already mentioned the aggressive or impulsive driving. We have a lot of girls. It will present as excessive talkativeness or impulse shopping habits, often impulsive relationship behavior. We often see things like other sorts of addictive behaviors like gambling and
I was just going to say,
substance
Andrew,
use. No, go, Jess.
Yeah, if I could jump in. So, I mean, just when you were talking about the lack of filter, you made me think of my father who had ADHD and truly was the definition of no filter whatsoever. And that got him in some trouble. But he also had an anxiety disorder. He had addiction, issues when it came to gambling problems and smoking. And so can we talk a little bit more about some of the comorbid conditions that might be co-occurring, or things maybe often, I don't know, are things misdiagnosed, or, are we missing ADHD diagnoses, or can we talk about that?
Yes, and it's all of the above. ADHD has a tremendous number of comorbidities. It's almost unusual for someone to have pure ADHD without any sort of comorbidity, and so it really does run in packs with other conditions. But it can also, when untreated, mimic other conditions as well. But the comorbidities can be different over time. Earlier in childhood, there are often things like the conduct disorder or oppositional defiant disorder, anxiety in adolescence and adulthood, more often mood disorders, major depression, bipolar disorder, like still anxiety, substance use disorders, binge eating disorder is pretty highly comorbid with ADHD. So a lot of the substance abuse, the binge eating, that those are also, we believe, highly reliant on the dopamine system. That the reward pathway in the brain, in the mesolimbic system, is a dopaminergic pathway. And so dopaminergic dysregulation can tie some of those together, but not all of them, because there's a lot of mood and anxiety comorbid with ADHD, and that's more reliant on the serotonin system to be very reductionist about it. So it really is a highly heterogeneous condition. Also, sleep disorders. Every person with ADHD has a sleep disorder, and that is nowhere in the criteria. So there is always concern about ADHD medication, especially stimulants, causing sleep problems. I, in my practice, tend to find it is the exact opposite, that most people, and I'm biased because I do see almost exclusively adults or very late adolescents, so it could be very different in younger children, but sleep almost always improves with ADHD treatment in my experience. And the way that I've heard it conceptualized, and I think, to me at least, makes sense conceptually, is that you have to be able to focus to fall asleep. If you're laying in bed and thinking about 27 different things at once, and then there's a light over there from something that's plugged in or whatever, how are you supposed to sleep with that? Or some branches rustle against the side of the house and like, oh, something's going on over there.
It is literally me. It is literally me. My partner goes to bed much later than I do. And if he comes into the bedroom and even turns the backlight on his phone, I am awake immediately. It doesn't matter if it's 3 a.m., 4 a.m., 5 a.m., whatever, I'm instantly awake. It's gotten better since I've started medication, but I do every now and then have to take something to help with the sleep stuff.
So what I was going to bring up is an anecdote that my poor wife, who is a social worker and therapist, who lives with all these people with ADHD in the household, says, you all take turns keeping me up all night. Because one of us stays up too late. At least one of us wakes up too early. One wakes up in the middle of the night, so on and so forth. And the other way that she puts it is that sleep is just too boring for you guys. Like,
That's so funny.
You're not wrong.
So just, talking about the way that some of these things present, I feel like, again, using a personal anecdote, that my son sort of has that like classic young boy, 7 years old, like hyperactive, can't stay in his seat, but he engages in what's been described as stimming. And I'm hoping maybe you could just like explain what that is, but like he'll, like these repetitive movements. And I don't know if you're watching on YouTube, you see like, he'll like rock back and forth. And he also chews on his shirt to the point where like, like you'll see, not to be gross, but you'll see like the saliva mark, or he'll chew on the sleeve, or he'll chew on the neckline. And my understanding is that it's sort of like a way of self-soothing. Is that right? Like, can you talk about what stimming is and what this all is?
Yeah. So and that's while on treatment, or is that off treatment that you're talking about? Okay. Because usually stimming, we tend to hear of it as part of taking stimulant treatment, which is where the word stimming would come from. That sometimes when on treatment, that there can be some kind of stereotypical behaviors, stereotypies that can take various forms. It can be kind of dyskinetic, choreoathetoid type movements, or it can be the also another term for this in the Parkinson's literature, where again there's dopaminergic replacement therapy, is punding, the very repetitive type behaviors. But definitely some of those stereotypical type movements are very common. One of my kids, my oldest son, he will be chewing on either the collar, or if it's a hoodie, the string, the rope string along with it, or the collar. And it can the amount of saliva can wick through to most of the chest. Sometimes he'll have chewing on it so long. Yeah. And I tell him to, look, you got to stop that, because he doesn't even realize he's doing it. So that's just, it's conceptualized as a kind of a self-soothing type of behavior. But it's one that can, especially for kids, can cause a lot of embarrassment. And so definitely want to address that. Right.
Craig, let's maybe shift gears and talk a little bit about how one might get diagnosed with ADHD, whether that be as a child or as an adult. And maybe we can also kind of, bundle in, we're seeing a lot of millennial women in particular being diagnosed with ADHD in their 30s and 40s, people that were born in the 80s and, late 70s, 80s, early 90s. And, certainly there's a lot of social media attention and there's a lot of memes circulating about ADHD, but it does appear that, things are changing in the scope of how it's diagnosed. So maybe you can walk us through some of those changes, as well as, how you would actually diagnose someone.
Sure. So in childhood, generally what gets the diagnosis are the hyperactive symptoms, because it gets you sent to the principal's office or the guidance counselor, and people take note of you if you're acting out, fighting, things of that nature. And so that starts to bring back a topic that you mentioned earlier, the gender divide. Because in boys, there's going to be more of a predominance towards hyperactive symptoms, and in girls, more of an inattentive symptom. And what's going to get you noticed and to be sent to a pediatrician or child psychiatrist, more likely that you can't stop yourself from fighting with other kids, or that you kind of daydream a little bit. And with our sexist society, girls aren't supposed to be good at math anyway, quote unquote. And so, you got to see that's great for you. Well, maybe not. Maybe with recognition and treatment of ADHD, if it were there, that could be an A+ student. So that's one problem right there, is that the disparities start early on. Also, that was compounded by the fact that in DSM-4 and previous, that the symptoms had to be recognized by the age of 7 years old. And that's can be kind of hard to remember if it's missed at that time. And DSM-5, which came out in 2013, that was one major change, is that the symptoms had to be manifest by 12 years old instead of 7. Now, that doesn't mean that it had to be recognized at the time, which is a very important distinction to make. So you don't have to recognize it. Just if you could look backwards and say, oh, by age 12 or previously age 7, then the symptoms were there. We just misinterpreted them. We missed them. But yeah, now that you mention it, that does make sense. And that's one thing I like to point out, is that there really is no such thing as adult onset ADHD. The person had it all along, but because of the factors I mentioned earlier, the advantages, the IQ, the scaffolding, the compensation, things like that, then it just wasn't noticed and wasn't recognized. But when you look back, okay, there it was. For me, for instance, how did I know that it wasn't normal to study 5 different subjects at the same time with all the different textbooks in front of you, with a baseball game on TV and the radio on? That was normal to me, but that was happening. And in hindsight, of course, no wonder it took me so long to study and retain things, but it seemed normal to me. Yeah. And so having that change in the age is, you mentioned the millennial women. Well, I think that's one big part of it, is that having that age change from 7 to 12. And then also the number of symptoms required. It used to be for any age, 6 out of a list of 9 hyperactive, or 6 out of a list of 9 of inattentive symptoms. And for people age 17 and above, it was reduced to 5 out of 9, because the criteria are going to become less and less accurate to someone's presentation when they're older than when they were younger, because they were written for young children, young boys. And so that's another big change, is that you can have meet fewer of the criteria, because that's going to be more consistent with what it might look like later in life. Yeah. Also, later in life, the hyperactive symptoms tend to diminish in a way, or turn more internally, and the inattentive symptoms become more prominent as people age as well, either male or female.
Yeah, and I was going to say, as people get older, they've been masking these their entire life, mm-hmm. so they may not be presenting with those symptoms, even if they're experiencing them, because it's just become second nature for them to mask those things. And I flash back to 8-year-old Andrea, who's reading the medical textbook Physician's Guide to Arthropods of Medical Importance to people who thought she was a little weirdo, and she thought it was the coolest thing ever. So yeah, it's encouraging, right? It's nice that we're starting to overcome this the sexism in medicine, the kind of the gender divide, the gender disparity. I'm also a little bit salty about it, though, and I feel like that's okay. But aside from kind of those very obvious clinical presentations, are there any other evaluations or testing that you might do for either a kid or an adult who you may suspect has ADHD?
So there are lots of different screening instruments out there. One of the most common ones for children and adolescents are the CPT, the Connors Performance Test, and the Vanderbilt. So those are 2 very common in children and adolescents. For adults, there's the ADHD-RS, ADHD rating scale. And then there are also the neuropsychological testing, which is 6 to 8 hours worth of testing with a psychologist, but that is not necessary to make a diagnosis of ADHD. I have a lot of colleagues, unfortunately, who, when seeing adults, that they will not make a diagnosis of ADHD unless the person has been undergone neuropsychological testing, which is and one of the reasons it's so unfortunate is because it's almost never covered by insurance, and it is very expensive. ADHD is a clinical diagnosis. And this is something that we really have to get through the stigma of, is that's usually the subtext of why the colleagues are saying that, is that they don't believe in adults with ADHD. And so they're trying to prove them wrong, basically, and trying to prove like, oh, no, you don't have this condition. I'll send you to neuropsych testing that your insurance won't pay for and you can't afford. And then you can't have the diagnosis. I withhold it from thee. And that's just wrong. Yeah. There's just a tremendous amount of stigma. So growing up and living and practicing in the South, I say only half jokingly that ADHD, when you're a kid, isn't treated with Ritalin as a kid. It's treated with a hickory switch in the South. and it's only half a joke for a lot of people. That's just, oh, you just need to behave. You just need to do the right thing and be a better kid or things of that nature. So while the hyperactive symptoms might become less common over time or become second nature, one thing that doesn't go away are the scars that it can leave. And I pulled up this quote because it's so it touched me so beautifully when I first read it, and it's by Dr. Margaret Weiss, who's a prominent ADHD physician, an MD, PhD. One of the most pervasive and debilitating attributes is that a life history of rejection and failure is now experienced as a shadow, casting unremitting doubt and self-deprecation on their sense of self. This is true whether or not they have succeeded or failed. It is the hallmark of adults with ADHD that their self-esteem eats away at them irrespective of how they are doing. And that's how I tend to see people in my practice, is that they didn't get the diagnosis as a child or adolescent, and they come in complaining of depression and anxiety. And they've been on many different antidepressants, but when I start talking to them, I mean, I feel like a bloodhound. I can smell ADHD a mile away because I've been there. I've been undiagnosed ADHD. I know how the ADHD storytelling is, and I know I can feel it. And then I do march through the criteria, of course, and everything. But and I tell them, well, look, of course you're depressed. You feel like you've been a failure. You've been told that you're unreliable, you're flaky, that you maybe didn't achieve what you thought you should have in school or in sports or in your career. And you're anxious because you're taking on too many projects. You're always under the gun, behind the 8 ball, because you procrastinated till the last second to try to get it done. Of course, you're depressed and anxious, but a SSRI isn't going to fix any of that, in my opinion, because I think that the core root problem is ADHD. And I think that will improve if we can treat that. Now, that doesn't mean that there aren't some people who do have truly comorbid generalized anxiety disorder or major depressive disorder, or what have you. But I do find that a lot of these people, when the ADHD is treated appropriately, they no longer need the antidepressants like they used to, because they're able to, the root problem is actually being treated, not just the symptoms trying to be addressed with a Band-Aid type of treatment.
Craig, every single time you open your mouth, I feel like I'm in a therapy session. Like, it's so soothing and comforting. You're just so wonderfully empathetic. I'm sure there are people listening to this who are like, how can I talk to Dr. Chepke? Or can we clone him? My goodness. I don't want to take us off topic, AJ. I know you had something to say. I'll hold what I was going to say. Do you want to say something?
Yeah. So I want to kind of segue this into, obviously, we're now recognizing that ADHD has likely been underdiagnosed. Many people have gone undiagnosed. And so we are seeing a lot of content on social media regarding—
This is what I was going to say.
Okay, perfect. Regarding ADHD, autism, other neurodivergent conditions, and so on. And so if you look at the data on social media, the hashtag ADHD, and this was as of last May, had 11.4 billion views on TikTok. Now, a recent study, and we'll link that, of course, had suggested that more than half of the content was misleading, and the content that was misleading were obviously posted by non-healthcare providers. The content that was posted by healthcare providers was overwhelmingly accurate and actually was found to be useful by people. So we're in this kind of double-edged sword situation, right? So misinformation is rampant in all shapes and sizes, but some people are finding that social media is allowing them to be aware of, considering the fact that maybe they had ADHD and then seeking treatment. So I'd love to hear your thoughts on, maybe the benefits of the attention on social media, and then some of the things that you might want people to be aware of when they come across this sort of content.
I think knowledge is power, and it's always important to be knowledgeable. And I love when people, when my patients do research and they're invested and engaged and activated in their healthcare. And the thing is to take that to your healthcare provider and then engage in a discussion. Because ADHD is underdiagnosed, but it also has the risk of being overdiagnosed as well. And part of that goes back to the name. If someone has difficulty at paying attention by virtue of speaking the English language, it would make sense that they have attention deficit disorder. but almost every DSM diagnosis, whether it's MDD, generalized anxiety disorder, bipolar disorder, on and on, have at least one criterion that states the difficulty focusing, difficulty sustaining attention. It's worded differently for each one. And so it could be a sign of something else. But I think it's very important that people are recognizing that it could be ADHD, because unfortunately, very often it was never brought up as a possibility, either to them or maybe even in their healthcare providers' minds. It just never occurred to them. And unless you consider something, you can neither lend support to or refute something. So I think it's great that we're having more awareness of these conditions, but we just have to make sure that we're not jumping too fast to conclusions, because there's always risk of harm. Most of the treatments for ADHD are stimulants, which are Schedule II controlled substances. And for people who do legitimately have ADHD, they are literally life-saving medications.
And really hard to get sometimes.
Yeah, unfortunately, more so recently than ever. Lots of shortages. But that calculus changes when it's someone who doesn't have ADHD. They have a different disorder that has some features that mimic ADHD. And then there's potentially cardiovascular risks, the risk of a non-medical use or diversion, just a number of different aspects. So just making sure that there's a good, accurate diagnosis, and that may be with a different healthcare provider than the person is currently seeing. Because many healthcare providers, like I said, don't believe in ADHD for adults, or don't believe in treating it, and they may need to find a provider with a more open mind to discuss it.
Yeah. And honestly, like, I've been to psychiatrists for 20 years, right? And have gone through the array of antidepressants and anxiety meds. And my brother had, really poorly managed bipolar. And ultimately, I know we spoke about this, he died by suicide. But it was my current psychiatrist, obviously when this all started, earlier in the spring, who was like, well, if you feel that way and you've tried XYZ, ABC, and all these other things, and you still have this, like, have you been evaluated for ADHD? And I was like, no. And then my partner was like, well, you've got like a pinball bouncing around in your head. And I was like, oh. And then it was like, oh, yeah. But of course, it wasn't self-diagnosis. It was diagnosis that was, in my instance, was actually brought up by my provider, and we kind of explored it together.
Similarly, I saw a psychiatrist for two different psychiatrists during the 4 years of med school weekly, the 4 years of residency at least once a week. He was a psychoanalyst, so sometimes we met twice weekly. And they always just diagnosed me with generalized anxiety disorder, which I believe I did probably meet the criteria for. But 8 years of SSRIs and psychotherapy pretty much fixed that. And then when I finished residency, moved to Charlotte and therefore had to get a new psychiatrist. He practically took one look at me and said, I think you need Concerta, not Celexa, for your problems. And then we discussed it more. And then that's how the diagnosis eventually got made. And my wife, who met me after all this happened, and as I said, is a social worker and therapist, I don't know how anybody ever missed this. It's the most obvious thing I've ever seen. So you can't find what you're not looking for sometimes. And if it's not on the differential diagnosis for a healthcare provider, then the diagnosis isn't probably going to be made.
Just a 30-second tangent. When we were talking about stimulants, Andrea, I was just thinking back to our college days and how there were a lot of people who were not diagnosed with ADHD who were
taking the Adderall.
Also, side note, do you remember that they had caffeine pills in the vending machines?
Yes.
I don't know if you remember this.
I do.
I took one once and it did not go well for me. I had to write a lab report. I was like my brain was asleep, but my body was like in overdrive. Not good.
Yeah, absolutely.
All right. So just going back to social media, which we've sort of acknowledged, double-edged sword, it helps raise awareness, it helps spread good information, but it also helps to spread misinformation and all that kind of stuff. And, on that note, we've seen a lot of myths about ADHD go viral. And maybe we could I know we don't have all that much time and we still have to talk about treatment, but maybe we could just run through some of these myths. The first that always crops up is sugar, that sugar is causing ADHD. That's not true. We know that. Of course, we don't recommend consuming excess sugar. That's not a good thing for, a variety of reasons, but it's not causing ADHD, right? Does anyone want to comment on that?
Yeah. And it's also not exacerbating ADHD. ADHD is not the same as having a blood sugar spike. Those are completely different physiological, psychological phenomenon. And ultimately this really goes back to demonizing carbohydrates, which is all based on misinformation to begin with. So we've talked a lot about food dyes with regard to a lot of topics. Of course, there's common misconceptions that are often underpinned by chemophobia or the undue fear of chemicals and the appear to nature fallacy, which people say that artificial food dyes, food colorings, and also preservatives in food worsen ADHD. There's no robust data to suggest this. There's some few limited studies amongst children that are looking at specific food colorings that, maybe have a correlation, not a causation. There are some flaws in the studies. There's confounding variables that weren't maybe parsed out. Just with anything that you consume or interact with, some people may have a poor reaction to something, other people may not. It's not, something that you inherently need to avoid or be afraid of if you've been diagnosed with ADHD.
Just like you can't find something you're not looking for, if you are looking for something, you're sure as heck going to find it.
Yep.
So if you have that expectation bias of, watch, I'm going to give him sugar and look what happens.
Exactly.
If you said the same thing for a steak,
Yes.
then you probably find, oh my gosh, steak makes his ADHD worse. So you just have to be very careful with these. And it's so heterogeneous. Maybe for one kid or another, maybe there is something there. But to make a blanket statement that that this highly heterogeneous condition that is so multifactorial is going to be always caused or exacerbated by this one specific chemical or food,
right.
It doesn't make sense.
And that goes to kind of all the other myths, right?
Exactly.
we need to have this rigid elimination diet. We need to avoid gluten. We need to avoid dairy. We need to have a special ADHD that's going to cure it. One example is the Feingold diet. Anything that's named for somebody is probably not a good idea. And anything that's excessively rigid or is eliminating very healthy foods. Certainly there's no evidence that any of these things have an implication or a therapeutic benefit if you have ADHD.
All right. So speaking of therapeutic benefit, let's talk about what we can actually do to treat or to manage ADHD. Craig, do you want to kick off that conversation?
The most common treatment for ADHD is one that's one of the oldest treatments that we have in all of psychopharmacology, which are the psychostimulants. So methylphenidate and amphetamines. These predate almost everything else in psychopharmacology. So 70 plus years worth of treatment. They've actually have kind of grandfathered their way past a couple FDA rules and requirements. It'd be very unlikely nowadays if amphetamine or methylphenidate were brought to the FDA for the first time today. I never know what FDA is going to do, but they would not be likely to get approved, in my opinion, based off the risk-benefit profile. But that's been the mainstay for over 70 years. And part of it is because they are extraordinarily highly efficacious in terms of standardized effect sizes. That means you don't have to know the specific rating scales. The amphetamines usually have a standardized effect size of 1 or greater, which is a large effect size. It can go to 1.1, 1.2, 1.3 in some studies. Methylphenidates will have a standardized effect size of 0.5, 0.6, medium to getting up towards large. And those are phenomenal. For contrast, antidepressants generally have a 0.2 to 0.3, a small effect size. Antipsychotics in schizophrenia will have 0.4, maybe 0.5 at best. So they are kind of head and shoulders more efficacious than almost any other treatment for the most other psychiatric conditions. Then there are also, but in addition to the stimulants, we do have a growing class of non-stimulants. For children and adolescents, there are the alpha-2 adrenergic agonists, clonidine and guanfacine. Those are notably not approved in adults. They are often used off-label in adults, but not approved. And then approved for children, adolescents, and adults, there are 2 norepinephrine reuptake inhibitors, atomoxetine, which it was initially developed to be an antidepressant, but didn't work as an antidepressant, and was the first approved non-stimulant for adults with ADHD, also shown in children as well. And then just a couple years ago, viloxazine extended release was FDA approved for first children and adolescents, then about a year later for adults. Interesting story with this one. It was actually used in Europe for decades as an antidepressant before it ever made its way to the U.S. It was taken multiple times a day. A company here put it into an extended release formulation, studied for ADHD, and showed very good results. And so it's now approved for children, adolescents, and adults with ADHD.
Craig, just a question about stimulant versus non-stimulant. What might help, dictate that decision making, whether someone try a stimulant or a non-stimulant?
Great question. So with most of the non-stimulant options, historically, they work very slowly. And so stimulants work very quickly. Within a couple days, we can tell pretty well if it's going to help them or not. And that's really almost the only thing in psychiatry that we can say that we can do very quickly. And so that was, and the effect size of the non-stimulants, it falls roughly in the medium range, generally 0.4, 0.5, somewhere around there on average. Could be even lower for some of them. So that relatively lower effect size versus the coupled with the longer time to efficacy has not been a great value proposition, so to speak, for treating ADHD in many cases. However, viloxazine extended release, though, does have a much faster onset. It's not days, but within a week or two, people can start to see a benefit there. And the great advantage of the non-stimulants is that they are not controlled substances at all, as opposed to the Schedule II controlled substance that all psychostimulants are. And also just the overall safety profile and tolerability profile is generally much better for the non-stimulants. So for people who don't want to be on controlled substances, well, non-stimulants are the way to go. Also, non-stimulants exert a 24-hour effect, whereas the stimulants have a shorter duration because we want them out of the system by the time we go to sleep. If we had stimulants in our system 24 hours a day, that wouldn't go so great. So that's a disadvantage to stimulants. And so if the duration, which could be either later on in the evening or mornings, because a stimulant doesn't start working until you swallow it, absorb it, and it goes through usually first pass metabolism in the liver. It takes a while to take effect. Whereas a 24-hour non-stimulant, well, that's working 24 hours a day. So it starts as soon as someone wakes up. And a lot of people with ADHD, their mornings are nightmarish because they can't get themselves up, organized, dressed, groomed, fed, off into the car with everything they need to. And so that can be a huge advantage for a non-stimulant. So it's individualized and personalized to what are the symptoms a person's having in terms of time of day, the tolerability and the risk aversion to certain aspects, convenience of having the 24 hours instead of sometimes taking multiple stimulant pills in a given day. Although with most newer stimulants that are extended release, they can cover most of the day for most people with some of the more very recent ones. So there's a lot of different considerations, I think. And also, there's a myth that amphetamines work better for adults and methylphenidate work better for children. And to me, a lot of that myth comes from that the first FDA-approved treatment for adults with ADHD was mixed amphetamine salts with the brand name Adderall. So when you define the market and own it solely for many years, of course, it's going to look like it's more effective because marketing works. And so in my experience, and there's some evidence to back this up, the evidence is greater in the children and adolescent side than in adults, but a good rule of thumb would be that about a third of people do best with methylphenidate, a third of people do best with amphetamine, and a third will do equally well with either. And I believe that applies to both the children adolescent side and to the adult side. And then that is not including non-stimulants in the equation. That's purely looking at the stimulant side, because the two FDA-approved non-stimulants for adults have shown efficacy, viloxazine probably a little bit greater than atomoxetine.
Interesting. What about non-pharmaco options? Are there, therapy-based options we could chat about?
Yes. So just traditional therapy can work for some people, but executive functioning coaching and ADHD coaching is very important and can be highly beneficial, especially or even as well to people who are receiving pharmacologic treatment. Because just like I mentioned that putting the treatment on helps improve the filter for it gives a tape delay for not saying certain things. Well, also, just because the attention is improved doesn't mean someone is automatically going to be able to organize well and prioritize well and know how to study or know how to triage different and multitask. Those are skills that they didn't learn when they were younger, and an ADHD coach may be able to help them with that specific. That's why it's called coaching, not a therapy. You're being coached to learn specific tasks that now, with the medication on board, then you're much more likely to be able to learn those and to put them into play than when the ADHD was not treated. So those are very important, and I think should be a part of all treatment regimens for people with ADHD. It's never just about a pill for anybody for any psychiatric condition. So I'm definitely glad that you brought those up.
Craig, what do we owe you for this session? Not joking. I'm sorry. I always learned so much from you. Really, this was so really illuminating, so comprehensive, amazing. Thank you so much.
You're welcome. And the answer is just to spend time with you both is all the payment that I would ever need.
Oh my God! Someone
Craig,
please look into cloning him. Okay, sorry, Andrea, go on.
I'll get on it. I got the genetic engineering toolkit. Craig, any last words that you want to leave our listeners with regard to ADHD or anything that we've discussed?
Well, I'm just really grateful that you asked me on to talk about this because I think it is very important and so underappreciated and can really help so many people. And if anyone out there is listening and hearing things that sound like you, find a healthcare provider who is willing to talk about it. We want to make sure that people are getting accurately, appropriately diagnosed and treated. And it's something that everyone should feel comfortable talking about. And it's nothing to be ashamed of. It's not that you just didn't try hard enough. You didn't work hard enough. You weren't good enough, even if that's what you're thinking, because I've been there. And look into it and see if it is that, or if it's not that, is there something else that could be actionable that could help to make your life better?
Absolutely. And what my psychiatrist said to me, which really resonated, was, you're very successful. You've done all of these things in your life, but it probably didn't need to be as hard as it was. So I think, that really validated, and I had never considered this as a potential diagnosis. I just always accepted, I check all the boxes for major depression and anxiety. And honestly, it felt like a weight was lifted, once I started medication, and I really did feel a difference within days. So, yeah, absolutely. Well, thank you so much, Craig. Once again, always incredible conversations, always filled with evidence. We hope our listeners learn a thing or two. So thank you once again. And to our listeners, if you want to support our efforts and help us grow the impact and reach of Unbiased Science, please feel free to consider supporting us. You can donate to us through our website or our Venmo account or our Coffee page. We also have some fun, snarky merch on our website, including our Got Aspartame or our Science is Sexy shirts. So try and pick up one of those. And you can sign up for our Substack newsletter at theunbiasedscipod.substack.com. And our website is www.unbiasedscipod.com. And make sure to subscribe to YouTube if you want to see our beautiful faces every single week. Our handle is at UnbiasedSciPod, the same handle as all of our other social channels. Catch you next time on the pod, your trusted source for no nonsense, just science.
I am a scientist. I am a scientist.